Good afternoon, everyone. This is Nancy Archibald from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this Working with Medicare webinar on coordination of Medicare and Medicaid behavioral health benefits, which is part of our training curriculum that we developed to assist states in better working with Medicare. Next slide. Before we get started, I wanted to go over a few logistics. For those of you who are joining by phone, you can view the slides by logging into Zoom. The instructions for doing that are located in the appointment that you received today for today's webinar. We'll also be sending the slide deck to all attendees after the call. To eliminate background noise, the phone lines will be muted. We will not be unmuting them for Q&A, but you can submit questions at any point using the Q&A icon at the bottom of your screen. And if we don't get a chance to answer your question, we can follow up with you afterwards. As you exit the webinar, a short evaluation survey will pop up on your screen. Just please take a minute and give us some feedback. Also, there's a place in the survey where you can ask additional questions if something comes to you. As usual, we're going to be recording the webinar so you can revisit today's presentation or share it with colleagues who were unable to join. Next slide. The Working with Medicare webinar series was designed for state staff who may be less familiar with Medicare than they are with Medicaid. This webinar should be especially helpful for new staff or those who could just use a refresher on how Medicare benefits overlap with Medicaid benefits and ways that states can integrate Medicare and Medicaid benefits for dually eligible individuals. Next slide. During today's webinar, we're going to cover Medicare program features of interest to state staff working to integrate care for dually eligible individuals, including a look at some clinical profiles and behavioral health expenditure data for dually eligible individuals, a description of Medicare and Medicaid behavioral health benefits, and some state approaches and options for integrating those benefits. Next slide. Today's webinar will feature 3 ICRC staff, Zaire Graves, Danielle Chelminsky, and Caitlin Murray. And now I'm going to turn it over to Zaire for the first section of our presentation.
Thank you. To set for the population that we will be covering today, I will be going over the dually eligible beneficiaries' clinical profiles, behavioral health expenditures, and their impact on the Medicare and Medicaid programs. Next slide, please. Behavioral health conditions are highly prevalent among dually eligible individuals. This chart shows the prevalence of 4 major behavioral health conditions among dually eligible individuals. It is separated by those under 65 and those 65 and older. As you can see, all 4 of these behavioral health conditions are more prevalent in the under 65 population compared to the 65 and older population. It's important to note that those under 65 become eligible for Medicare because they have complex medical and behavioral health conditions. So one would expect to see higher rates of these conditions among the under 65 eligible population compared to the 65 and older population. Next slide, please. This slide compares opioid use and high-dose chronic opioid use among dually eligible individuals and Medicare-only individuals. As you can see in this graph, from 2006 until 2015, the dually eligible population demonstrated consistently higher rates of any opioid use as compared to the Medicare-only population. In addition to having higher rates of any opioid use between 2006 and 2015, dually eligible individuals also showed higher rates of high-dose chronic opioid use than Medicare-only individuals. In 2015, twice as many dually eligible individuals received high-dose opioid prescriptions than Medicare-only fee-for-service This slide shows that dually eligible individuals with mental health conditions often also have chronic physical health comorbidities. For example, in dually eligible individuals with mental health disorders, 75% also had a heart condition and 42% also had a musculoskeletal disorder, like chronic neck or back pain. This has important implications for care management. The data for this slide was taken from a CMS analysis conducted in 2014 and is linked at the bottom of this slide. Next slide, please. The data for this slide was derived from a report by SAMHSA that looked at the total expenditures for all kinds of services for mental health disorders and substance use disorders by payer in 2015. As you can see, Medicare, shown in lime green, covers a good portion of mental health disorder services and only a small sliver of substance use disorder services. If you take a look at the chart on the right, you can see that Medicaid, shown in gray, covers a substantially higher percentage of substance use disorder services. Next slide, please. Now this slide looks at the impact on total spending for dually eligible individuals that have a mental health disorder versus those who don't. As you can see, spending is much higher for dually eligible individuals who have a mental health disorder. Next slide, please. If your state is interested in finding out about the dually eligible individuals in your state specifically, we recommend using the Medicare, Medicaid Linked Enrollee Analytics Data Source, or MMLEADS file on the CMS website. This file is a great resource to find data on full benefit, partial benefit, Medicare only, Medicaid only beneficiaries at the national and state level. Although this data is from 2012, the characteristics of this population doesn't change much from year to year. States can use this resource to find data on chronic conditions, such as the percentage of people with Alzheimer's in their state, or service utilization, such as the percentage of people using one or more Medicare or Medicaid community or residential mental health service. This data is helpful to compare types of beneficiaries within these variables, compare states to other states or to the national average, and ultimately help develop tailored integrated care programs based on the specific demographic makeup in your state. We have some examples on the following slide of how you can use this data. ICRC has also developed a CMS data resources guide that walks you through how to use this file and other related files as well. The link is included at the bottom of this slide. Next slide, please. This slide just shows some examples of charts made using the data from the MMLEADS file. The top graph shows the percent of those with bipolar disorder in Maryland compared to the national average and each type of beneficiary. As you can see, Maryland has a higher percentage of those with bipolar disorder in each one of the categories. The bottom graph shows the percent with at least one Medicare or Medicaid community mental health service in Florida compared to the national average. As you can see, Florida has similar percentages at the national average with a slightly higher percentage among full benefit dual eligibles and Medicaid only beneficiaries. And with that, I will hand it over to Danielle to discuss behavioral health benefits.
Great. Thank you so much, Zaire. So for this section, I'll be summarizing Medicare and Medicaid coverage of behavioral health benefits, which includes mental health services and substance use disorder services. And I'll also quickly go over some recent policy changes as well. Next slide, please. Okay, so I'll start off with Medicare. So Medicare coverage of mental health and substance use disorder services follows the same structure as Medicare coverage of physical health benefits. Medicare Part A covers mental health and substance use disorder services in an inpatient setting, such as a general hospital or a psychiatric hospital. Medicare Part B covers services provided in outpatient settings by approved mental health care professionals. Services covered under Part B include individual and group psychotherapy, psychiatric diagnostic interviews, and other related services. And the types of providers that Medicare covers tends to be more restrictive than Medicaid, but they include psychiatrists, nurse practitioners, and clinical social workers. And the full list of the types of providers that Medicare covers are in the resources at the bottom of the slide. And finally, prescription drug coverage under Medicare Part D includes medications to treat mental health conditions and substance use disorder services. Next slide, please. So one important Medicare policy change that may have significant impacts for states is a new Medicare opioid treatment benefit. As of July 1st of this year, Medicare now covers opioid use disorder treatment services for people with Medicare Part B coverage. Under this new benefit, Medicare covers medication-assisted treatment, counseling and therapy, and other related services. And one recent update to this benefit that I should mention, about 2 weeks ago, CMS issued an interim final rule that allows providers to use audio-only telephone calls rather than requiring two-way interactive audio-video communications for therapy and counseling provided under this benefit during the COVID-19 pandemic. And we've included a link to that interim final rule as well as other COVID-19 related resources in the appendix. Next slide, please. So this new Medicare opioid treatment benefit has several implications for states, for beneficiaries, and for providers. The implications for states is that some of the costs of these services that Medicaid traditionally paid for could be transferred from states to the federal government, since now Medicare is the primary payer for dually eligible individuals who receive services from these opioid treatment programs. And the impact on beneficiaries is that the Part B copayment for these services will be zero in 2020, but the Part B deductible will still apply. But for dually eligible individuals who are in the Part B deductible phase, CMS will cross over the claim to Medicaid for adjudication. And the impact on providers is that those who treat opioid use disorders will need to enroll as Medicare providers to be able to receive Medicare payment. And to prevent any disruptions, CMS released guidance to states and providers on continuity of care strategies for dually eligible individuals. And CMS also encourages states to reach out to Medicaid opioid treatment providers and advise them to enroll in Medicare as quickly as possible so that they can receive Medicare payment. Next slide, please. So another set of recent Medicare policy changes comes from the Comprehensive Addiction and Recovery Act of 2016. And this law gave Medicare plans certain flexibilities to address opioid overutilization through what are called drug treatment programs, drug management programs. And through these programs, Medicare health and drug plans follow clinical guidelines and work with prescribers to identify beneficiaries who are at risk for opioid addiction. And once a beneficiary is determined to be at risk, there are certain actions that plans can take or to address potential addiction. Next slide, please. And this slide outlines those actions that plans can take. So one thing plans can do is to prevent at-risk beneficiaries from switching plans outside of the standard Medicare enrollment and special election periods. Another action plans can take is they can limit access to opioids and other frequently abused drugs by only allowing a beneficiary to receive medications through specific providers and pharmacies. The third action plans can take is that they can use what are called point of sale claim edits to prompt prescribers and pharmacists to do a safety review of the prescription to see if it actually is appropriate and medically necessary. So states that have integrated programs for dually eligible individuals may want to consider aligning their Medicaid managed care practices with these new Medicare practices. And as of right now, these flexibilities are actually optional for Medicare plans, but they will become mandatory in 2022 through the Support Act. And we provided a link to more information at the bottom of this slide. Next slide, please. So now we'll turn to Medicaid coverage, starting with mental health services. States are required to cover certain mental health services, such as services delivered in inpatient and outpatient hospital settings, rural clinics, nursing facilities, home health settings, and physicians' offices. But beyond these required services, states can choose to cover a variety of optional services, such as non-medical support services. And many of these optional services even go beyond what Medicare covers. And if you look at the chart on the right, we listed how many states cover certain mental health services as of 2018. And as you can see, most states cover individual therapy, inpatient psychiatric hospitalization, crisis intervention, but fewer states cover psychosocial rehabilitation and psychiatric residential treatment, although the number of states covering those services has increased in recent years. And as for prescription drugs, according to a 2016 MACPAC report, all states cover prescription drugs for mental health treatment, although Medicare covers those drugs for dually eligible individuals. Next slide, please. So Medicaid also covers certain substance use disorder services. For medication-assisted treatment, all state Medicaid plans currently cover buprenorphine and naltrexone, and almost all states cover Suboxone and methadone. However, as I mentioned earlier, Medicare will now typically cover medication-assisted treatment for dually eligible individuals. And there are actually many types of substance use disorder treatments that lots of states cover, such as detoxification, psychotherapy, peer support, and crisis intervention. And if you look at the chart on the right, it shows how many states are offering different types of services along the continuum of treatment. And some states cover more of these services than others. Next slide, please. So I want to quickly turn to talk about institutions for mental diseases, or IMDs. IMDs have become somewhat of a hot topic in Medicaid in recent years, and these facilities provide inpatient care for those with substance use disorders. IMDs are inpatient facilities with more than 16 beds in which over half of the patients are being treated for behavioral health conditions. And while Medicare covers inpatient psychiatric facility services through Part A, as we talked about earlier, not all IMDs actually qualify as inpatient psychiatric facilities. And historically, federal law has not allowed federal Medicaid dollars to pay for IMD services for Medicaid beneficiaries between the ages of 22 and 64. And this is what is known as the IMD exclusion. Therefore, states have had to use their state-only dollars to fund IMD services for this population, which has limited their availability. Next slide, please. However, states now have multiple options to cover IMD services for the adults that were historically excluded. And these coverage options include 1115 waivers, Medicaid managed care in lieu of authority, disproportionate share of hospital or DISH payments, as well as a state plan option created by the Support Act. And the Kaiser Family Foundation recently released a report that provides much more detail on these flexibilities, and that resource is listed at the bottom of the slide, along with the state Medicaid director letter from 2019. Next slide, please. So nearly every state is using one of these flexibilities that I mentioned on the previous slide. And the chart on the right shows how many states are using each of these options as of November of 2019. And with that, I'll turn it over to Caitlin to discuss state approaches and options to integrate Medicare and Medicaid behavioral health benefits.
Great, thanks, Danielle. So in this section, we'll go over some challenges and opportunities for integrating Medicare and Medicaid behavioral health benefits, including examples of how some states are already doing this, as well as an overview of D-SNPs and the implications of their new integration requirements. Next slide, please. So to set the stage for why integrating behavioral health benefits is important, let's talk about some of the different layers of fragmentation that duly eligible individuals with behavioral health needs encounter. In many cases, these individuals are navigating separate care delivery systems because often physical and behavioral health services are not provided by the same source. At the same time, they're also often navigating different programs because there's this interplay of how and when Medicare may cover services versus how and when Medicaid may cover services. There's also this added level of complexity in that there may be grant programs at the federal, state, or local level that are separate from Medicare and Medicaid that may cover behavioral health services as well. In terms of the actual services themselves, there's this consideration that mental health services and substance use disorder services are often provided by different systems and different provider types. Next slide, please. So there are implications for the ways in which Medicare and Medicaid cover behavioral health services differently, and how that sometimes leads to a lack of coordination among payers. Medicare covers prescription drugs for duly eligible individuals, but there are often significant coordination issues in Medicaid nursing facilities and in HCBS waiver programs, where providers may not always be aware of an individual's prescription drug use. Medicare and Medicaid each have their own coverage limitations, and gap filling coverage for each program is often not coordinated, which Danielle touched upon in her summaries of Medicare's limited substance use disorder services and Medicaid's IMD exclusion. In addition, Medicare has limits on certain types of behavioral health providers, and often there are challenges for care coordination due to a lack of information sharing. Next slide, please. So in recent years, Medicaid programs across the country have trended away from providing behavioral health through fee-for-service and instead have moved towards providing those services through managed care. However, in many states, managed care purchasing models continue to separate or to carve out behavioral health services from other covered services, as shown by this 2019 Kaiser Family Foundation bar graph depicting carve-in status and MCOs by state. So often behavioral health services are administered and regulated by multiple state agencies and levels of government, even if there's only one health plan providing both physical and behavioral health services. So, for example, a state could have a Department of Mental Health that's working in conjunction with the state Medicaid agency to deliver those services. There is a growing trend towards integrating physical and behavioral health benefits in managed care models, which is something we'll get into in the next slide. Next slide, please. So this slide contains some examples of how states are already working to coordinate and integrate physical and behavioral health benefits for duly eligible individuals. The first example is comprehensive carve-in models, which are used in Massachusetts, Tennessee, and Texas, and which incorporate all physical and behavioral health services under one managed care organization. Specialty plans for beneficiaries with serious mental illness integrate physical and behavioral health services under one plan, but only for a very specific high-need population that's carved out of Medicaid. So Arizona is an example of a state that uses this type of model. Arizona also uses a hybrid model, and that includes a mix of carve-in and carve-out services, which is based on the level of care needed. Coordinated carve-out models are seen in Michigan and Pennsylvania, which retain separate plan management of physical and behavioral health services, but rely on contract partnerships and incentives to encourage collaboration between plans and systems. Next slide, please. So let's dive a little bit deeper into Arizona. Arizona is interesting because they went from carving out behavioral health services to carving them in, with the exception of serious and persistent mental illness. So there were a few factors that led to this change, including starting with a regional pilot that they ultimately scaled up to the statewide level, as well as an organizational restructuring that consolidated their behavioral health agency with the state Medicaid agency. Ultimately, if Arizona was building this from the ground up, it's possible that they may not have chosen a hybrid model. But Arizona looked at the history and structures that were already in place, and they leveraged those to build towards greater integration. So the lesson here is that there is no one-size-fits-all approach to integrating these benefits, and the approaches that states take will very much be done on a case-by-case basis. It will be influenced by their particular Medicaid and behavioral health landscape. Next slide, please. So Michigan is another example that we wanted to highlight because of the work they've done to develop the backbone for information sharing. Some of the things that they've done to encourage this are to contractually obligate data sharing between the plans and their subcontracted behavioral health organizations that administer behavioral health services. They also do this through the ongoing development of CareBridge, which will be used to facilitate information sharing, as well as through creating standardized forms and processes for data sharing. They've also required the plans and their subcontracted behavioral health organizations to establish care team meetings to discuss shared enrollees. Next slide, please. So dual eligible special needs plans, also known as DSNPs, are another way to facilitate the integration of physical and behavioral health benefits. DSNPs are a type of Medicare Advantage plan designed for dually eligible individuals. They must at least coordinate Medicare and Medicaid benefits, although in some cases, states contract with DSNPs to cover Medicaid benefits. They must also have a model of care that describes how they will assess enrollee needs, coordinate care, and develop care plans. States are not required to contract with DSNPs, but DSNPs are required to have a contract with the state Medicaid agency in every state in which they operate. Those contracts must include certain requirements, but many states also choose to include additional requirements to improve coordination of benefits. We've also included a link to an ICRC resource on DSNP contracting within this slide for those who may be interested in learning more. Next slide, please. So recent legislation passed requires that all DSNPs must meet at least one of two new integration requirements as of January 1st, 2021. The first option is to cover Medicaid behavioral health services and or long-term services and supports, which would allow the DSNP to be designated as either a fully integrated dual eligible special needs plan, or a FIDE-SNP, or as a highly integrated dual eligible special needs plan, also known as a HIDE-SNP. The designation between a FIDE-SNP and a HIDE-SNP would depend on the level of coverage. The second option is to notify the state and or its designees of Medicare hospital and skilled nursing facility admissions for at least one group of high-risk enrollees. The motivation behind doing this is to try and improve coordination during care transitions. So whether a state can designate a DSNP as a FIDE-SNP or a HIDE-SNP will depend on whether the state includes substantial behavioral health and or LTSS coverage in its capitated contract with the DSNP, its parent organization, or another entity owned and controlled by the DSNP's parent organization. And it will also depend on what entity holds the capitated contract with the state. We've included additional information on the major attributes of FIDE and HIDE-SNPs in the appendix slides for those who are interested in learning more. Next slide, please. So there are some challenges to physical and behavioral health integration. Data sharing in particular can pose a challenge due to privacy considerations, limited financial and staff resources, and limited adoption of electronic health records by mental health and substance use disorder providers. Another challenge is having quality measures and payment incentives in place to promote provider accountability, both of which require some level of financial resources. There are often administrative barriers to program monitoring and quality improvement, which is inherent in having separate Medicare and Medicaid payers, as well as separate state-level mental health and substance use disorder systems. Different cultures of care delivery, as well as separate professional training for physical and behavioral health professionals, also pose challenges. Next slide, please. So integration is one option for addressing a lot of those challenges. And while the models used by states may vary, there are 5 crucial components to consider across all integrated care models, including understanding and building upon the different cultures of behavioral and physical health care and services, identifying opportunities for information sharing, designing care management and coordination, reframing provider training and developing program monitoring and quality improvement process. Next slide, please. So based on what we've covered today, there are several opportunities for states to drive integration, including making administrative and payment changes, developing a backbone for information sharing like Michigan is doing, using contract requirements to encourage and enhance connections for care coordination, and developing strategies for program monitoring and quality improvement. A lot of the information in this section came from an ICRC technical assistance brief on the lessons learned from states working to integrate physical and behavioral health for dual eligible enrollees. We've included a link to that brief here for those interested in diving a little deeper into this. Next slide, please. That concludes my section, so now I am going to turn it over to Nancy for questions.
Great, Caitlin, thank you so much. That was a great presentation. So now we have a good chunk of time for Q&A. And again, if you'd like to ask a question, you just roll your cursor down to the bottom of the screen. There should be a Q&A icon. You just type your question in there, come right to us. So there was a lot of information in that presentation. It may take you a little bit of time to digest and really think of your questions. But let's start maybe with a question going back to Danielle's presentation. So Danielle, can you talk a little bit more about how the IMD exclusion and recent policy changes would affect dually eligible individuals?
Yeah, definitely. That's a good question. So dually eligible individuals that are in an institution in one of these IMD facilities that's Medicare certified will continue to be covered for medically necessary mental health and substance use disorder services for up to the lifetime maximum, which is 190 days. But if a dually eligible individual exceeds that 190 days, or if they're in an IMD facility that is not Medicare certified, there would be gaps in coverage for those who are between the ages of 22 and 64 because of the IMD exclusion, and Medicaid federal dollars can't be used to pay for that population, as I mentioned earlier. However, the new flexibilities that I talked about on an earlier slide allow states to use federal Medicaid dollars to cover this population. So if Medicaid can now cover some of these services under one of those new flexibilities, there'll be a lot more opportunities to coordinate care between institutional and community-based care post-discharge.
Great, so that's good to know, and that would be really helpful. So Danielle, you had also mentioned that opioid treatment providers have to enroll in Medicare to receive Medicare payments for their services. What happens if they aren't enrolled yet or their enrollment hasn't been approved yet?
Yeah, so in that case, states must pay the claims for opioid treatment services delivered to any dually eligible individuals by Medicaid enrolled providers who, if those providers are not yet enrolled in Medicare, to the extent that that service is covered under their Medicaid state plan. But to avoid any of the disruption in treatment for dually eligible individuals, states have a couple of options on what to do in the interim until Medicare approves that provider's enrollment. So one is that the state can choose to continue to pay the opioid treatment claims for dually eligible individuals for a period in early 2020 until that provider is approved. And then once a provider becomes Medicare enrolled, Medicaid can then recoup all of the Medicaid payments from that provider back to the effective date of that provider's Medicare enrollment. And then they can advise the provider to bill Medicare to receive those services. So they can still get they can still recoup those funds. And then another option is that states can advise the opioid treatment providers that they can hold the claims and bill Medicare once the provider becomes Medicare enrolled. So they can hold off a little bit before they can bill Medicare. And this process will allow Medicare to review the claim and then cross the claim over to Medicaid for a payment automatically. So that will kind of smooth over the process a little bit. And CMS encourages states, I think I mentioned this earlier, CMS encourages states to help opioid treatment providers to enroll in Medicare if they haven't already. So some of these processes can be avoided that way as well.
Great. Thanks, Danielle. So I neglected to mention that we also have a couple of other ICRC colleagues on the line. We've got Aaron Weir-Lakmani and Jim Bradier, who are also available to answer questions. And I think I might throw this one that came in to one of them. Medicare behavioral health provider qualifications seem to be more stringent than those for Medicaid. This is something that they've observed in Pennsylvania that's causing some issues. As just a reminder, Medicare is the primary payer. Is this something that's occurring in any other states, and is there anything happening at the federal level that would address this?
Yeah, I'm happy to respond to that one, Nancy. And Danielle has a link actually in one of her slides, in the slide that talks about Medicare coverage for mental health and substance use disorders. She has a little bit of information in a footnote on that slide, and she also has a source link that is relevant here. One of the things that is really noticeable throughout the country when it comes to Medicare coverage of behavioral health services in comparison to Medicaid is that Medicare only reimburses certain types of providers for mental health and substance use services. And in many states, the types of providers that Medicaid will cover for behavioral health services go beyond that shorter list that Medicare has. So it is not uncommon to find in a state that there are certain providers that are able to bill Medicaid, particularly certain types of community-based providers that may not be a physician or a licensed social worker or a nurse practitioner. And so they may not meet that qualifying list of provider types that Medicare will cover. And so those providers may only be able to bill Medicaid when they're serving dually eligible beneficiaries because they simply don't meet the criteria to enroll as a Medicare covered provider. I would lay odds that that's probably the root of the issue of what the person who asked the question is describing. Although if it's not, feel free to send more information through the chat, and we're happy to follow up.
Great. So another question that came in was on the new integration standards for DSNPs, and particularly around the coverage of behavioral health. So Caitlin, if you could, would you again explain the difference between FIDE and HIDE SNP and how coverage of behavioral health falls in those two categories?
Sure, yeah. So, to be considered a HIDE SNP, a plan must provide either directly or through a companion Medicaid managed care plan, either long-term services and supports or behavioral health services, as well as other Medicaid services to its dually eligible members. So by contrast, FIDE SNP must provide Medicaid long-term services and supports and may also provide behavioral health services. So that's kind of the high-level summary, but in the slides that we'll be sending out after this presentation, there are more details on the differences between FIDE and HIDE SNP in the appendix.
Great, thanks, Caitlin. And for Aaron, just to clarify, there was a second part of that question, and they wanted to know if to be a HIDE or a FIDE, if any level of behavioral health carve-in would count. So could they have just sort of the SMI population or acute care population, and would that, as long as it was within what the state policy required, that the plan could still be categorized as
Could
HIDE or
qualify.
FIDE if they had that. Yeah.
Yeah, so that, and there is another link in our appendices that will be helpful on this. CMS issued some guidance specifically on carve-ins and carve-outs of behavioral health or LTSS services with regard to the FIDE and HIDE SNP designations. That guidance was issued in January, and it is available on the CMS DSNP page, which we've linked to in our appendices. And that guidance essentially said that carve-outs of certain services are allowable if it is consistent with state policy. So that, you know, the state is the one deciding to carve that coverage for that particular subgroup or coverage for that particular service out of the benefit. And the carve-out impacts, the carve-out has minimal impact is essentially the language that's used. So the carve-out does not impact like the entirety of the dually eligible population enrolled in the plan, for example. Maybe it only impacts a particular subset, like individuals with developmental disabilities who have co-occurring serious and persistent mental illness, for just, you know, as an example. So there are ways that limited amounts of behavioral health benefits could be carved out of a plan's coverage, and that plan could still qualify as a HIDE SNP or a FIDE SNP. But essentially the plan has to cover substantially all behavioral health services or substantially all LTSS services. And so I would encourage folks to check out that January guidance because it goes into detail and offers some really valuable specific examples around how much of a behavioral health or LTSS benefit really needs to be covered. That guidance also explains overlapping service areas, which is really helpful when DSNPs have affiliated Medicaid managed care plans that may operate in some of the same service areas, the DSNP, but not all. So that guidance is helpful for that as well. And the CMS guidance that has been released has also been really helpful in explaining who the contract needs to be with. So one of the main distinctions between FIDE SNPs and HIDE SNPs is that to be a FIDE SNP, the same legal entity needs to cover the Medicaid benefits and the Medicare benefits. In a HIDE SNP, you could have affiliated entities that are operated by the same parent company. And I know that's a bit of legalese probably for many of you, but for those of you who may work at health plans or who may work in states heavily with the DSNP contracting, that's an important distinction as well. So that CMS guidance, again, there's a CMS DSNP page link in our appendices where you can get to all of that.
Great, thank you, Erin. So back to Danielle. I can't remember which slide it was on. Maybe you can look that up for us real quick. But you had talked about a recent change for Medicare Advantage plans that they could allow audio-only televisits for behavioral health, and that person just wanted to verify that that was so, and to find out where they could find more information on that.
Yeah, so that is specific to the interim final rule that came out a few weeks ago, specific during just the COVID-19 pandemic. So this is for beneficiaries that are receiving opioid treatment, therapy, and counseling. CMS is now allowing audio only, so just a telephone call as a to count as a visit, where it used to be audio-visual communication for opioid treatment. And that was really meant to provide additional access to services for those who may not have access to audio-visual communication technology. And there's a lot of, if you go to the appendix, we have a whole slide of more COVID-related resources that includes that final rule. And I just want to note that the expansion of telehealth in Medicare for using telephone visits there's a lot more information on when you can use a regular phone visit versus under some circumstances, Medicare providers will still need to do audio visual. So all of that is is in the appendix slide where there's lots of, if you go to the Medicare COVID-19 information page, there should be a lot more information there, and definitely encourage people to go to SAMHSA's website as well and CMS's partner toolkit.
Great, thanks, Danielle. And so another attendee had a question about COVID-19 and who was looking for a summary of changes that had maybe been made to coverage for duals around mental health. And so these resources should be really helpful for you, I hope. So we had a question which is not directly sort of behavioral health related, but it's more about how Medicare is the primary payer for dually eligible individuals, and that then Medicaid becomes the secondary payer. And they seem to be a little confused about how that payment works. So they were asking a question about that. So for example, they said that Michigan reimburses services for LTCs under Medicaid, but Medicare does not. And so that they were thinking that the individual who is dually eligible could not get Medicaid to bill for those, they couldn't get those services covered under Medicaid because they thought Medicare had to be it had to be covered under Medicare. So maybe, Jim, could you give us just like a quick and dirty explanation of how that payment process works for duals, and what happens when things are covered under Medicaid but not Medicare, and how those services do get paid?
Yeah, the basic rule is that if Medicare would provide the service, and it would be provided through an authorized Medicare provider, then under those circumstances, Medicare would have to be billed first. But if there are situations, and there are in the behavioral health area, where some providers, social workers, for example, without sort of medical training, Medicare just would not cover services provided by that kind of provider because they're not eligible to provide Medicare services. Under those circumstances, a state could say that it's just not necessary to bill the Medicare provider first because, or bill that provider first, or have that provider bill Medicare first, because Medicare clearly would not cover that service. So it would be a futile exercise to require that. There are some cases where it's not as clear whether Medicare would cover a service or not. And under those circumstances, a state might well require that at least there be an attempt to have the Medicare program pay for it. But then if the Medicare program comes back and says, no, we don't pay, then Medicaid would pay.
Great, thank you, Jim. And for the person who asked that question, if you still need more explanation, you can contact us and we can explain that to you. Okay, so here's one I do not know the answer to. Maybe, Aaron, this might be for you. So they want to know if there have been any K amendment changes that are behavioral health related. I do not know the answer to that. Do you?
So not exactly, but I can point you toward the resources. So, because I haven't read through the specific guidance related to K amendments. So K amendments pertain to waivers that are often used for long-term services and supports. I want to say it's 1915C waivers off the top of my head, but I may have the the alphabet soup wrong there, so don't quote me on that. But I'm sure the question asker is well aware of which type of waiver they're talking about. So as many of you have probably seen, CMS has been releasing new guidance on a daily basis related to the COVID-19 crisis for both Medicare and Medicaid. And Danielle has given some resources, and we have the slide up on the screen with those COVID-19 related resources. On the page, the CMS waivers page, and also on the Medicaid.gov coronavirus page, there's a main sort of coronavirus page within Medicaid.gov as well. Both of those have links to resources that states can use to apply for amendments to their various state waivers as well as to their state plan to make changes to how Medicaid is operating in light of COVID. So for example, states can make adjustments to allow beneficiaries to self-attest to their income and assets to make eligibility a smoother and more streamlined process right now during COVID. That's just one example. There are thousands of examples of things that states can do to improve access to care for beneficiaries, to use more telehealth and phone-based methods, as Danielle has already walked through for certain things. So there is a template and lots of information in FAQ documents on those COVID-19 information pages that talk about the specific, the K amendments that states can submit for their long-term services and supports waivers. I don't know offhand, if there are any elements within that that are specifically pertinent to behavioral health. I'm sure there may very well be, but that's where I would point you, is to the Medicaid.gov COVID page and the CMS waivers page here. The CMS waivers page that's on the slide that's up is actually, well, it might have some, sorry. It may have some, and the Medicaid.gov page has those templates for the K waivers, and also it has the FAQs, which are updated almost daily as well. So I would search those FAQs for the K waiver information, and I would also look at the K waiver template to see if that helps provide relevant information.
Great, thanks, Erin. That's a good resource. Let's go back over to Zaire. So Zaire, you had some really interesting slides. Can you tell us why it seems that opioid use is so much higher among duly eligible beneficiaries than Medicare-only people?
Sure. So there may be a variety of reasons why spending on these services has been increasing, but several pieces of legislation have been passed in recent years that have aimed to increase the mental health and substance use recovery services. And each of these new laws have led to additional spending. For example, the Mental Health Parity and Addiction Equity Act and the Patient Protection and Affordable Care Act required parity and insurance coverage of mental health and substance use treatment. The Affordable Care Act also increased access to insurance coverage overall. In more recent years, the Comprehensive Addiction and Recovery Act, or CARA, and the Support Act have both led to increased coverage of behavioral health benefits as well. Though it's important to note that the statistics presented on slides 10 and 11 predate both CARA and the Support Act. The SAMHSA report cited on the slides 10 and 11 provide more information about the impact of legislation on behavioral health spending and treatment. So you can access that report to learn more.
Great, thank you. So if there's new access to treatment possibilities popping up. So related to that, Danielle, how does Medicare's new opioid treatment benefit work for duly eligible individuals enrolled in Medicare Advantage plans? And what about Medicaid benefits that are provided through Medicaid managed care? How does that work?
Yeah, so if a dually eligible individual is enrolled in a Medicaid managed care plan, then the state may delegate Medicaid coverage of opioid treatment services to the Medicare, to the managed care plan. In these cases, the Medicaid MCO may receive those crossover claims directly from Medicare, or another option is that your state can forward the crossover claim to the MCO, and the provider's remittance advice will come from that MCO. And then for Medicare Advantage plans, and that includes DSNPs, Medicare Advantage plans have to cover opioid treatment services as of 2020, so as of this year. And original Medicare doesn't have a copayment for these services, as I mentioned earlier, but there may be some copayments under Medicare Advantage plans, but there's no automated crossover processes for dually eligible individuals enrolled in a Medicare Advantage plan. So that means that providers will have to bill the state Medicaid agency or the Medicaid managed care plan directly for any Part B deductible and any sort of co-payments as well.
Great, got it. Thank you. Let's see, one last question, I think. Caitlin, for states that are really just beginning to think about integrating behavioral health and physical health benefits, is there a model that you can recommend them looking to?
Yeah, that's a good question. You know, I think for every state, it's going to be a little bit different. You know, how they approach it is really going to depend on the Medicaid and behavioral health landscape within their state. And, you know, the history and structures that are already in place are really going to be what influence the systems that they ultimately build. So, you know, for example, if a state is currently providing Medicaid behavioral health services through, you know, specialized behavioral health MCOs, those MCOs will need to have some kind of role going forward. So again, it's going to be done on a case-by-case basis. I don't think that there's necessarily one model that's the best or that would be, you know, the best fit for every state. I think some models may work great in some states, and in some states they just may not be feasible.
Yep, good advice. So we are just about out of time. There were a couple of other questions that we are not going to get to, and we will follow up with people offline. But I did want to say thank you to all of our presenters and our partners at CMS, and for all of you for joining us today. We hope that this has been helpful. A recording of the call and the slide deck will be emailed to all of the attendees and also posted to ICRC's website. The website does have links to our other webinars and our technical assistance resources. Again, if you're logged into Zoom, please complete the survey that's going to appear, and also we'll send that survey out through the email with the slides and recording. So thank you all for joining us today, and have a great rest of your afternoon.